I'm Nicole Neal, and today I'll be talking about myasthenia gravis, otherwise referred to as MG. Acquired myasthenia gravis, MG for short, is actually quite an uncommon disorder, although I feel that most nurses are aware of the disease process. Specifically, MG is a type of autoimmune disease that is characterized by muscle weakness that changes, worsening upon exertion, and getting better with rest. Additionally, in about 2/3 of all patients, there is some sort of involvement by the extrinsic ocular muscles, known as EOMs, present at initial symptoms. Eventually, this can progress to involve other muscles and limbs, which result in another form of MG, known as generalized MG, or GMG. There are varying factors that influence the possible occurrence of MG, sex and age appearing to be two of the most common. Women are more commonly diagnosed with MG earlier in life, meaning before the age of 50, while males outnumber women when it comes to people diagnosed with GMG after the age of 50. MG is classified into 5 main classes containing multiple subclasses by the Myasthenia Gravis Foundation of America, known as MGFA. These classifications go from 1 to 5, with 2, 3, and 4 having an A and B subcategory of MG. Class 1 MG is characterized by the ocular muscle weakness and possibly eye closure and eye opening weakness, while all other muscle strengths are normal and unaffected. Class 2 MG is classified by mild weakness that affects the muscles and may include ocular muscle weakness. Class 2A is characterized by mainly affecting limbs, axial muscles, or both, and may have a minimal involvement of the oropharyngeal muscles. In contrast, Class 2B predominantly affects oropharyngeal, respiratory muscles, or both, and may have lesser involvement of limbs and axial muscles. Class 3 is classified by moderate weakness that affects muscles other than ocular, as well as ocular muscles of any severity. In contrast, Class 3A predominantly affects the limbs, axial muscles, or both, and has a lesser involvement of oropharyngeal muscles. Directly opposite to that is Class 3B, in which predominantly affects oropharyngeal and respiratory muscles, while having a smaller effect on limbs, axial muscles, or both. Class 4 is characterized by severe weakness that affects muscles with ocular muscle weakness. Class 4A predominantly affects limbs, axial muscles, or both, while Class 4B affects oropharyngeal and respiratory muscles, while having a lesser involvement from the limbs and axial muscles. And finally, we have Class 5. Class 5 is characterized by intubation with possible mechanical ventilation or the use of a feeding tube due to severe respiratory involvement. As stated previously, MG is an autoimmune disease, but to go even further into the pathophysiology, MG is an autoimmune disease of the neuromuscular junction, known as the NMJ. This is caused by antibodies that attack varying components of the postsynaptic membrane, resulting in an impaired ability of neuromuscular transmission, which can lead to weakness and fatigue in the skeletal muscles. This weakness and fatigue can either be generalized or localized to specific muscle groups, with possible involvement of the respiratory muscles being life-threatening. Furthermore, the pathogenesis of this disease process depends upon the target and isotype of the varying autoantibodies. Most cases of MG are caused by IgGI and IgG3 antibodies to the acetylcholine receptor, known as AChR. These antibodies produce complement-mediated damage and increase the rate of AChR turnover. While both mechanisms cause the loss of AChR, from the postsynaptic membrane. Additionally, the thymus gland can have some involvement in this. However, in a proportion of patients without AChR antibodies to muscle-specific kinase, MuSK, or related proteins are present. This seems confusing, but really what happens is that IgG antibodies bind to AChRs, which result in the activation of the classical complement pathway with assembly of the membrane attack complex known as MCH. A flush of calcium from the MCH causes damage to the membrane, and the damaged postsynaptic membrane has a diminished response to ACH, which ultimately causes muscle weakness. The cardinal feature of having MG is weakness that fluctuates with fatigue, which means that it is weakness that worsens with repetitive activities and improves upon rest. It is worsened by heat, exposure to infection, and stress. The fact that this is a disease process that fluctuates and changes distinguishes MG from other disorders that are similar and present with the same type of weakness. Most commonly, the weakness involves specific skeletal muscle groups, and the weakness is usually ocular, bulbar, proximal to extremities, and the neck, and may involve the respiratory muscles. The most common initial symptom experienced by patients is ocular muscle weakness, which occurs in nearly 85% of patients. This initially develops as fluctuating ptosis and blurred vision, and will generally progress within 2 years. Upon objective clinical evaluation, there is usually more than one extraocular muscle that is weak, with pupillary sparing. Furthermore, bulbar muscle involvement is seen in approximately 60% of patients with MG, which presents as fatigue when chewing solid food. Symptoms of this include painless dysphagia, although respiratory muscle involvement is rarely present in the first 2 years of onset. Respiratory muscle weakness can lead to myasthenic crisis, which can be life-threatening. This means that these patients would require mechanical ventilation or feeding via an NG tube to reduce the risk of aspiration. The involvement of the limbs in MG causes mostly proximal muscle weakness, which is similar to other myopathic disorders, although the arms are most commonly affected over the legs. Distal muscle involvement is occasional. Eventually, the weight of one's head may be too heavy for the arms, which can produce something known as the dropped head syndrome. Over time, this severe weakness is associated with the high mortality rate at 5 to 9% of all patients who have MG. The role of the Christian advanced practice nurse when caring for patients with MG is unique. This is not only a disease process that affects someone's physical being by terms of weakness and possible respiratory effects that could be life-threatening, but a disease process that will weigh heavily on one's mind and mental health. Specifically, it is important for the nurse to try to understand how difficult it might be for one to have a disease that is likely to progressively get worse over time and cause worsening muscle weakness that would negatively impact one's life. Symptom management and education by the nurse is vital for maintaining quality of life via patient advocacy, and really listening to the nurse's patients is vital. Due to the fact that this disease process can be fatal, the use of prayer and other methods that could bring safety and peace to patients during this difficult time is very important. Many patients, although they may not have considered themselves religious before being diagnosed, will seek spiritual strength through faith or other methods. So it is important for the Christian nurse to remain non-judgmental and open to the discussion and offering to pray with or for patients and educate about the Bible at any point throughout their disease process. And here we are with the final page of this presentation, which is the reference page. I hope that this presentation was helpful to you all as you study for this week's quiz, and I look forward to listening to all of your PowerPoints this week. Thanks!